Right, good morning everybody. Welcome to the October public board meeting for the CQC. We have an apology from Mark Saxton, who is unavoidably elsewhere. Rosie is joining us remotely, self-isolating in a very precautionary way. I think that's all we need by way of apology. Particular welcome to Jasper Jackson, who comes from our LGBT plus equality network. You're very welcome, Jasper, and do feel free to contribute as we go through this. I also want to welcome three of our clinical fellows who are observing. Clinical fellows are a really important part of the CQC community, and I've enjoyed working with previous clinical fellows and look forward to getting to know even better the current clinical fellows. So you're extremely welcome. I also would welcome colleagues from Campbell Tickle who are observing the board as part of our part of our board effectiveness review. So you're all very welcome. We are socially distancing in the board today, so we're very spread out. I don't know what that looks like if you're viewing this online, but can I just say to the board, you do have to wave quite vigorously to catch my eye, particularly those at the other end of the room, but do please do so. I think that's all. Oh no, sorry. Before we move on, are there any declarations of interest anybody needs to make other than those that are recorded elsewhere? Okay, that's excellent. So let's then move on. We have the minutes of the board from September. Are they a true and accurate record of everything we discussed? Yep, thank you. So they are approved. We have no outstanding actions on the action log. We're doing really well on this. Are there any matters arising that aren't otherwise covered on the board agenda that follows? Good, in which case we can move swiftly on, Ian, to the executive team report, please.
Thanks very much, Peter, and good morning, everybody. So firstly, I'd like to just kick off and cover off the appointment of chair. The Department of Health and Social Care are continuing to progress the appointment of a new chair following the end of Peter's tenure at the end of this year. Peter's very kindly agreed to extend his term for a short period to ensure a smooth transition, which we hope will be complete by March of 2022. I want to move on and talk about Net Zero. I'm part of the Net Zero Health and Care Committee, a group from local governments and the NHS, aiming to coordinate joint action to get the health and care system to net zero. We'll be working with others to support the national net zero ambitions through regulation. I expect to see us bringing forward proposals on how we might do this in practical terms to the board in due course. October's been quite a busy month for awareness-raising campaigns. We've had some particularly powerful sessions supported by our Race Equality Network for Black History Month, and I think it's been a really positive celebration with some really, really powerful sessions with a range of high-profile speakers. We also ran sessions for World Mental Health Day, which includes sessions highlighting different mental health experiences at work. And again, we've had some very powerful sessions from colleagues sharing their particular experiences of various of mental health and mental ill health. October is also Speak Up Month, with this year's theme being Speak Up, Listen Up, and again we've been contributing to the awareness raising around that. So that's all I've got to say, Peter. I'm happy to take questions on any of that before I hand over to Kate. Thank you.
Okay, Kate, it's over to you. Thanks, Ian.
Thank you, Peter, and good morning all. So the first thing I want to talk about this morning is the social care workforce. So colleagues will be aware there's been lots of conversation in the media, and if you talk to stakeholders and people who work in social care, there is growing concern around the exhaustion levels and challenges around recruitment and retention of the social care workforce. And those concerns we've been hearing anecdotally and we've been hearing from providers is starting to be reflected in the information that's returned to us. So I look forward to talking publicly about this more in our State of Care report that we publish this Friday. So just want to flag significant growing concerns around the workforce and welcome a conversation about that towards the end of the week. Second thing I just want to update on is our work around closed cultures. So this board will be aware we've had an extensive programme of work around ensuring us as a regulator that we can be as effective as possible at identifying places at risk of closed cultures and regulating those services effectively. We have a new dashboard for our inspectors that goes live in November, bringing together all the flags that may trigger concerns about a service potentially being a closed culture. We've also rolled out extensive guidance for our inspectors around our new quality of life tool. So this is our new way of regulating that enables us to really get under the skin of services at risk of closed cultures. We've had that guidance live for a while. We're refreshing it and we're continuing to evaluate that approach, which to date is appearing to be pretty effective at enabling us to hear people's experiences of what it feels like to receive care in those settings. And we are continuing to survey our staff about their understanding. So we've developed a new way of working, we've rolled out training and guidance, and we now need to be doing the assuring stuff that inspectors have digested it and are feeling confident in implementing it in how they regulate. Thank you.
Thanks, Kate. Any Robert?
Thank you. And I just wanted to ask about the social care workforce, and I appreciate that State of Care will no doubt say more about that. But I just wondered two questions, really. One is the extent to which the current problems, which of course are long-standing, do we have a take on how much that has been changed or impacted on by the vaccination requirements? That's the first question. The second, a more general one, which is the extent to which the problems increasingly being faced in the social care workforce patch is impacting on our ability to require and enforce acceptable standards.
Thank you, Robert. So, as you say, the issues around recruitment and retention in social care workforce has been around for a long time. Prior to the pandemic, Skills for Care were reporting 122,000 vacancies and a turnover rate that varied between about 37 to 40%, depending on the role. So we know for a long time we've needed to do something different around recruiting and retaining people in this sector. There are a number of things that are going on at the moment. So we've seen big impact around kind of tourism. We've seen quite a disproportionate impact around the country, in particular coastal towns, where workforce has become even more challenging as people haven't gone abroad and tourism in this country has really boomed. On the 11th of November, as you say, the requirement for everyone working in a care home and social care to have their 2 jabs done comes into force. We've been really clear that our approach and how we regulate the government's requirements on this is that we'll be proportionate in our approach when we go into services. We are going to focus increasingly on workforce in our coming months. So I'm really keen that we can talk about how workforce at a kind of national level is impacting on quality, and we are thinking about how we may introduce some kind of focused questions on up-and-coming inspections to ask providers to talk to us about impact on workforce, on their ability to deliver care. With regard to your second question, so our expectations around standards of care have not changed because we are here on behalf of the public, and the public should expect high-quality standards of personalised care. So we expect those standards to still be delivered. However, we are also happy to talk about a kind of national picture where we may see workforce impacting a quality of care, but we are not lowering our standards about what we expect people to be receiving from their social care providers.
Belinda.
I just wondered if there's been a reduction in nursing and residential care beds as a result of the workforce challenges. Have you seen beds being deregistered or an increased number of care homes closing?
Thank you for that, Belinda. So it's going to look like a lot of my answers are trailing the State of Care report, but we do, on Friday, we will be talking about the intelligence we hold, particularly in our market oversight. So our function that looks at large and hard to replace providers. We will be talking about our insights into occupancy levels, but also the total number of residential and nursing beds that are available.
I think Kate, it's probably worth saying that at the end of the day, this is a bit of a zero-sum game. There is a massive shortage of labour in the country, across pretty well every sector. So if you've got a fixed pool of people who can take jobs and another fixed pool of vacancies, and the vacancies is bigger than the number of people available to fill them, it's going to be a challenge. And the challenge for the care sector, I mean, obviously there are people with very specialist skills, but there are also a lot of people that have very transferable skills into other sectors, and everybody's fighting for the same small pool or same pool of people, not necessarily a small pool. So, I mean, I think this is just a huge challenge, isn't it, Kate?
Yeah, and it's keeping pace with the current workforce demands, and also recognising that this workforce needs to grow as well. So if we think about fabulously more people living longer into older age, supporting people to live well in the community, this is a workforce that we not only need to recruit to and retain, but also we need to grow. And in order to do that, we need some new plans about how we can make that happen.
Good. Are we happy to move on? Having failed to solve that problem, let's move on, Ted, I think, to you.
Thank you, Peter. The situation that I've described at previous board meetings around urgent emergency care, the pressures on that we've seen throughout the summer has continued. The members of the board will no doubt have seen some of the performance data that came out last week from NHS England, which showed that increased number of patients are waiting more than 4 hours for admission to for treatment or admission to hospital in accident emergency, but also increasing number of patients waiting more than 12 hours. And the figures as reported on 12 hours are the figures from the time of decision to admit, not from the time of arrival in A&E. So the number of people waiting more than 12 hours in A&E is way beyond the 5,000 quoted for September. And I think it's really important to emphasise that the pressures in A&E are causing significant problems for patients accessing care. And it's really important that there's focus on this. I have to say we've stayed in close contact with accident emergency departments throughout the country. I've spoken previously to the board about the work we've been doing with them. We'll be issuing some new guidance next week, building on our Patient First initiative from a workshop we did with clinicians and executives in accident emergency and ambulance services last week. But they report back that the staff who are working in the emergency departments are under intense pressure. And just as Kate was talking about the exhaustion of the social care workforce, I think it's important to emphasise that the staff are feeling exhausted after what has been a really very long summer on the back of the pandemic, and going into winter where respiratory viruses and other illnesses are likely to increase. Clearly we are concerned about the pressures and the ability of the system to cope with that. Interestingly, it isn't just COVID patients that are driving the increased demand, it is non-COVID patients as well. And it does appear that the COVID pandemic has had a change on the way people behave and how the system works, with the result that a lot more patients are, as they've been attending throughout the summer and are attending as we go into autumn and winter going forward. And some of those are not related to COVID at all. But of course, COVID is still present, and one hospital told me this week that 30% of their inpatient beds were occupied with COVID patients. It does vary from hospital to hospital. That is probably the highest I've heard recently, but there's a significant portion of beds in most hospitals that still have COVID patients in, and that of course affects their ability to admit patients through A&E, as does the ability of the hospitals to discharge patients to social care, either care home or care in their own home. And so it's important to recognise the way that all these systems are interlinked. I'm also concerned about ambulance trusts, and I highlight that in the report. Speaking to ambulance trusts, they've all been at the highest level of escalation really now for several weeks across the country. They're all affected by this, and they're all concerned about their ability to manage the pressures. Because of delays admitting patients to hospital, inevitably that means ambulances are being held at hospitals for far too long, which means they're not available to go out and do calls for other people who need care. The ambulances, again, are working very hard. Their staff are under enormous pressure, and they themselves are exhausted as well. So it's important to see that this is a problem throughout the system. They have remarkably well maintained the response to the most urgent calls, the life-threatening calls, C1 calls, but you can see in the response times for less urgent calls, the urgent emergency calls, non-life-threatening, that the time response times have deteriorated over the last month or two, and that is a real reflection of the pressure ambulances are under. Likewise, we worked with them on the workshop a couple of weeks ago, and we will be publishing guidance to try and help them. But this is a whole system problem throughout the urgent emergency care system. And I think it's important to emphasise this is a system problem. It's not a problem with individual providers. We will need to work very closely going forward with them. We're working closely with NHS England and other parts of the system to try and make sure services get the best possible support. Despite all these concerns, I've also highlighted the report we published on the Isle of Wight NHS Trust in the last few weeks. I highlighted this at the last board, but couldn't name the trust. I think now is an opportunity to name the trust. It is remarkable how that trust has improved despite the pandemic over the last year or two. And I'm really pleased that the trust has been rated as good now, having been in special measures now for a couple of years. So real tribute to the staff in that trust, but also the other parts of the system that have supported that trust in driving those improvements. It is really good to see that despite the pressure of the system, there still is a really dedicated workforce that is driving improvements day to day in services.
Thanks, Ted. Anybody? Sally?
Thanks, Peter and Ted. It's really encouraging to see the Isle of Wight example, Ted, and I'm sure there are more across the country, and I wondered whether at a future board you might be able to give us a flavour of trends, I suppose, and some of this good practice that's, you know, could be applied elsewhere in the areas where they still need improvement. So we've honed in on one, haven't we? But I'm sure there are lots of other good and bad examples we could use.
Yes, and we are now going back to inspect those trusts that were in special measures or were rated inadequate to follow up on them that haven't raised new concerns with us. So to some extent, we are now beginning to discover that improvement. During the pandemic, we've predominantly been inspecting services where new concerns are identified. So inevitably that does weight our ratings towards poorer ratings. But I think we're now, the programme of inspections we're doing at the moment is going back to those other trusts. And I'm anticipating there will be some more good news about other trusts in the next few months. But we need to do the inspection first, Sally.
Thanks, Ted. Anybody else? Great, good. So thank you, Ted. Rosie, over to you.
Thank you very much, Peter. And firstly, apologies I can't be with you. I have symptomatic teenagers with positive lateral flow tests, and we're all awaiting PCRs. So we felt it was probably not appropriate for me to join the board in person. So thank you for bearing with me online. Just to echo some of the comments that Ted has made, we are continue to see very huge pressures across primary care and all of the other sectors that are in my portfolio, and we are working closely with stakeholders to look and see how we can support as much as possible those practices that are struggling with demand. Just in response to Sally's point as well, we have done a significant amount of work with special measures practice, and it's been really great to see the improvement in many practices over the last few months as we've gone back to re-inspect them. And I'd be very happy to bring more information back to the board around that, because we've seen practices improve despite the challenges of the pandemic, and really turn their services around to deliver much better quality care for patients, which is excellent. In terms of the report gives the board an update of our work that we've been doing with integrated care systems and local authority assessments, assurance work. And I've been very involved looking in discussions with stakeholders around our proposed work with integrated care systems, as the board outlines. And I just wanted to reflect the fact that these proposed changes are getting a very positive response from the stakeholders that I've been discussing it with, and the opportunities to make sure that we get good care right across all parts of the health and care system, and the system works together, has been very well received. We've also set up an external advisory group. We think it's incredibly important that we bring in external voices. We use people's expertise in how we develop our plans going forward, and so that has been set up and is progressing. Thank you.
Thank you, Rosie. Any questions, comments? Kate.
Thank you, Peter. So I was really pleased to chair the first expert advisory group, I think it was last Monday, looking at local authority assurance. And we really benefited, as ever, from having people who receive care around the table, families, and then a multiple of stakeholders. We used that group to ask about their ambitions, about where we might focus our efforts when it comes to local authority assurance. So a really rich discussion that started off with LA local authority assurance will move to integrated care systems. But again, just the value of having people who draw on care sat around the table with stakeholders helping to shape our thinking was just something to kind of note and celebrate.
It's good. It's the way to go. Anything else, or should we move on? Okay. Tyson. Sorry, Kirsty, I beg your pardon. I'm moving on far too fast.
So I am actually going to hand over to Chris, who's going to take you through the performance data.
Thanks, Kirsty. Yeah, so this is the first update on performance against our new business plan, but we'll also be doing a quarter 2 review next month. So I'll just give a brief update, and then there'll be a fuller pack next month with visuals. So the business plan's focused around 3 areas, which is delivering our regulatory business, transforming to deliver our strategy, and managing our people and resources. So just a few areas to pull out for this month in terms of delivering our regulatory business. We're constantly monitoring the regulatory activity we do as we adapt our approach. For the year to date, 10% of registered services have had some form of regulatory activity, be it an inspection or a monitoring call. Alongside this, we're regularly assessing our approach and have undertaken 61 quality assurance inspections. This helps understand if our risk assessments are delivering the right outcome. And then finally in this area, in terms of registration, we're aiming to reduce the average number of days across our registration applications by 15%. So in simple and normal applications, we've almost met this target with a 13.1 and 14.4 reduction respectively. In the transformation to deliver on our strategy, all current milestones are on track for our change programme, and there'll be a fuller update on the change programme next month as well. In terms of managing our people and resources, quite a few of our measures in this space don't fluctuate month on month. We continue to monitor this, but again, there'll be more update on that in quarter 2 report. And finally, in terms of finances, at the end of August, revenue budget's underspent by 7.8 million. That's forecast to increase to 12.9 million, and the capital budget is underspent by 2.7 million, and that's forecast to be on budget by the end of the year. Thank you.
Thanks, Chris. I'm under strict instructions from Chris that we are to make this board meeting as quick as possible so he can get back to Newcastle to celebrate his wedding anniversary. So nobody's allowed to ask any questions of Chris. Seriously, are there any points that people want to raise with Chris? Because there's a lot in that performance report. Well, I've done your job for you, Chris. Please tell your wife I tried. Okay. Now, it really is your turn, Tyson. Sorry about that.
Thank you, Peter. I've got nothing to add to my written report.
So Chris has obviously instructed you as well to be brief. Any questions for Tyson? Okay. Mark?
Thank you. There are no significant information or cybersecurity incidents report this month. I'd just like to add that we have ongoing continuous improvement activity in the cybersecurity space to seek to continuously improve our security position. An example of that is recently, in tandem with Cybersecurity Month, we've run a campaign with a series of training and information exercises, which has included some dummy phishing emails to test colleagues' knowledge, and that will help inform and target our next training exercises. So it's an ongoing area of improvement.
So Mark, Do you have sight of what other organisations, across different sectors are doing in the cyber security space, and are we, doing everything that we should be doing, and everything that everybody else is doing?
So I'd say our approach with our cybersecurity is to assess ourselves against the standards, so the ISO 27001 cybersecurity, information security standards are the kind of the gold standard. So we absolutely assess ourselves against that. We use external partners to support us with making sure that we comply with those, and it's a constantly moving landscape, so that we are ensuring that we are performing all the activity to make sure that we keep ourselves safe. And we do work with other agencies, particularly within the health and care landscape, to ensure that we are joined up with our other colleagues and learning from others as well.
Thanks. I mean, it seems to me that, obviously from our regulatory point of view, it's really important we understand what's going on in health and social care, but actually cyber is a thing that affects absolutely everybody, and there are probably people in other sectors doing some quite interesting things to make sure they are as cyber safe as they can be. That was my point. Sally.
Peter, just to provide a little bit more reassurance, part of our internal audit plan is quite a deep look at cybersecurity, and that reported back to the last meeting. So Mark and his team will know that they're in quite a good place, and there are some further recommendations they're picking up over the next few months.
Great, thank you, Sally. That's good to hear. Anything else? In which case, thank you, Mark, for what you're doing. Chris.
Just a couple of things to add to the report, where we talked about the evidence given to the Public Services Committee and the Health and Social Care Committee. Today, the government has published details of the, which includes CQC's oversight of the system. It imposes a new clause, a new duty on the CQC to carry out reviews and assessments into the overall function of the systems and the provision of NHS care and adult social care within each area of the integrated care system. So I think that's quite a positive move. The clause is very much in line with the conversation we've been having with DHSE. Obviously, there is more detailed work to do, but I think this is in the right place for us moving forward, and hopefully should complement our work on transformation and our new thoughts around how we intend to regulate in those sectors. I should give colleagues a note that's happened just this morning.
Which is really good news. It would be really worrying if it didn't happen, Indeed. But it's really good to know that it has happened. So thank you for that update, Chris. And Chris, did you want anything else?
No, that was anything I want to add to.
Okay, that was Chris's celebrations are obviously infecting the whole board. We're running ahead of time for once. That's excellent. So let's move on, Sally. I think it's on to you and the ACGC report.
Yep, thank you, Peter. The minutes from the last meeting are in the pack, but just to say the Audit and Corporate Governance Committee, called ACGC, met on the 6th of October. It comprises CQC board members, independent members from outside our organisation, and also our internal audit and external audit colleagues from the National Audit Office. We looked at the internal audit plan and the 3 reports that had been completed as part of that work and the management responses. We are obviously close to the point of laying our annual report and accounts, subject to some feedback through the National Audit Office about local government pension schemes, which delays many people, many bodies laying their accounts. But our particular audit found nothing to be concerned about, and we're hoping to lay our annual report and accounts as soon as we can. In terms of risk, we also look at the risk register as we do at other committees. No significant changes there. And just to follow up the comment I made about cybersecurity, we looked specifically at data, CQC's data across 3 risk areas: the data that we actually collect, the systems that we use to collect it, and cybersecurity. We also look at our transformation programme, which is reviewed by a separate subcommittee. And as we've heard, that's in a positive place. We also twice a year look at counter-fraud, and there were only 4 cases in this last period with no evidence to support those claims. So we look forward to laying the accounts, and our next meeting is in January 2022. Thank you.
Thank you, Sally. Sally, do we have a expected time for laying the accounts, or is it still in the lap of the gods?
I'll look at Chris and say, not sure at the moment.
I think we're aiming for November, all being well.
That would be good.
That will be ahead of some other organisations who are also subject to the delays around local pension scheme audits.
Fine, thank you. Anything else? Okay, we're flying along. Robert?
We are now 3/4 of an hour ahead of when Imelda was expecting to have to be here, and she is on her way but not in the building at the moment.
So how far away is Imelda?
I'm seeking to establish that.
You may be flying solo. That will really test you.
Of course, I'd be absolutely delighted to do that, but for reasons which become apparent, this is not a meeting where that would be particularly appropriate, I'm afraid. And so, with apologies to Chris, obviously.
Seriously,
I'm trying to find out where she is.
Because there's
nothing else.
We can't. Yeah, there's nothing else. So we can either pause the meeting until Imelda gets here, which is okay. We can do other things. But if she's only a couple of minutes away,
I think on this occasion I would propose that. I could easily put the report before you, but I think we'd like to see her off the premises.
Okay, so what I'd like to suggest is that we do just pause the meeting. And we've got some other business we can use the time to fill, and then we will restart the public board meeting when Imelda gets here. Okay? Well done. This is a... Okay, let's now resume our meeting, and apologies, Imelda, that we threw you by, for once in our lives, been ahead of time, and so far ahead that you had to run to get here. So thank you for doing that. Robert, over to you.
Thank you. I'm not going to steal Imelda's thunder in relation to her report, but I think I have to note that this is her last board meeting. So if I may just be permitted a couple of remarks about Imelda. I think it's fair to say that under her stewardship, Health Watch England has been transformed as an organisation, both in its effectiveness, its reach and its profile. And I think this report from her shows and is very strong testament to how now the voice of the patient and the service user really has never been heard so effectively. The organisation nationally has matured and is increasingly listened to and influential in relation to policy decisions being made. The support given to the local network is increasingly effective and appreciated. And I ask colleagues to remember that Health Watch England has virtually no levers of direction in relation to local Health Watch. It is entirely a matter of building relationships, offering support to sometimes fiercely independent local organisations. Internally, I can testify to her leading a fantastically hard-working and, if I may say so, very cheerful team who've coped with the pandemic extremely well. So in all, Chair, never has a chair's role been so easy as it has been in supporting Imelda in her fabulous work over the last few years. So I'd just like, on our behalf, to thank her for that, and hope let her give her report.
Imelda.
Thank you. Thank you very much for that. You're making me blush, Robert. I'm mostly not shy, apart from when there's compliments coming, then I get really shy. So, well, thank you for your time today. You've got the written report in front of you. What I'll do is just do really quick trot through some of the headlines. there are lots of this work we're sharing with CQC as we develop it and build it, so that we're often doing it together as well. So the first thing that I talk about in my report is the work that we've been doing on hospital discharge. As you know, during the pandemic, we moved to discharge to assess, so people being moved rapidly out of hospital. But we wanted to make sure that that was working for people, because the theory is a good theory, but what's actually happening on the ground. So we've done a lot of work with partners on identifying what works and what doesn't work, and we've seen some change in the guidance to ensure that people aren't just pushed away from hospital but without the right support around them. There's still a lot of work to do on that, and I think that that's not an issue that's not going to go away for a long time because of the lack of support that there can often be in local communities. We have done quite a lot of work over the last few months on digital exclusion, the move to digital services, and where that works for people and where that doesn't work for people. And just this morning we were feeding a lot of that into NHS England about what, you know, who are the people that it's really great for and who is it the people that it doesn't work for, and how do we segment that and remove some of the heat that's in the conversations at the moment, which is digital bad, face-to-face good, because that's not what the public are saying. They're saying something much more nuanced than that. Of course, some of our work, like some of your work, is just stopping things happening rather than making things happen. And we did a lot of work around patient data when if you remember, there was a hard deadline where the people had to, were being encouraged to opt in, but they weren't told there was an opt-out. So we did quite a lot of work on that, knowing that we had quite a good backlog, a good catalogue of information from the public on that issue. And so the position we're in now, I think, is a better position as a result of that. We've done a lot of work and will continue to do a lot of work on the elective care waiting list, which is a big issue for the NHS. It's a big, it's a big mountain to climb. And our role in that is to start looking at, well, what does it mean for people? How can you make it better for them while they are waiting? How can you communicate with them in ways that eases some of that stress and tension? And again, all that work is feeding directly into NHS England. And some work we published with the King's Fund just 2 weeks ago showed that people in the most deprived areas were waiting the longest for their surgery. So there is a real inequalities angle to these waiting lists, and I think one of the things, the task for us all, is to ensure that we're not widening inequalities whilst we're restarting up our services. I think we've reported to you before about the terrible state that dentistry is in this country, and the significant numbers of people who cannot get access to good dentistry. There were difficulties in parts of the country pre-pandemic. That is much worse through the pandemic, and now also people are finding it incredibly difficult to get NHS treatment when they need it in a timely way, and that's having a huge amount of impact. It's the thing the numbers that we're hearing from has just shot up over the last year compared with, we always heard quite a lot about it because in parts of the country access is very, very difficult, but that has completely shot up. So that's again something that we're working with to see with NHS England to see what can be done to ease that those points of access. We have done some work on an integration index, because one of the issues is if we're going to talk so much about integrating services, how do we know whether it's improving people's experience of care or not? So we've been looking at doing some pilots around some metrics around that, and that piece of work is going very well. A piece of work that came out of work that we did some time ago around before the long-term plan was published, about what are the things that the public talk about in terms of being able to participate fully in their medical care. And one of the big things that came up was transport. And Simon Stevens at our conference announced that the NHS would do a review into it, and that's been published now. So there are some significant changes to the way non-emergency patient transport is dealt with to try to make those situations better for people. There's still a lot to do in that area, I have to say. Just moving on through, we have done quite a lot of work around admin. You'll all know this from your personal experience. One of the big frustrations people have with health and social care is the way things are administered, the letters you get that don't allow you to make appointments, the call back and there's no answer, that sort of work. So we've done quite a bit of work on that to help services understand the impact that that has on people. Just looking a bit to the future, we will continuing our work on making sure that Healthwatch is ready for the ICS and for the new organisations that will appear before next April. So we're trying to get ICS ready, which is complicated for Healthwatch because Robert and I yesterday just met with one of the ICSs. They have 9 Healthwatch in their patch. Others have 10, 11, you know, it's a complicated piece of work. And we're looking both at having Healthwatch roles properly acknowledged within the legislation and the guidance, but also as a proper infrastructure to be put in so that we can support Healthwatch to engage properly and that their insight has a real impact within the ICS boards and the partnership boards too. We're also doing quite a lot of work around equalities. It is a main thread of our strategy. All our work takes that angle to make sure that we are not leaving people behind and that we're amplifying the voices of people who are less often heard. We are building towards a campaign that will be run right across the country with most Healthwatch participating, which is about accessible information. And how do we make sure that the information, well, there is a duty to have accessible information. There are standards around it, but but over time people move away from that, and so what we want to do is highlight again the impact that it has around when information is not accessible. So I think that's the top line of what's going on in Healthwatch England. It's very busy. It's very, I have to say, very energetic. It's a great place to be at the moment. And just my final comment is I just wanted to, at my final meeting, to just say a thank you and to appreciate the work that colleagues in CQC have done to support me over the nearly 5 years I've been in the organisation to really help develop and mature the organisation. So a huge thanks to you, both infrastructure, policy, everything. Everybody's been really fantastic, so thank you.
Thank you, Imelda. I think Rosie's probably going to make the point that I was going to make, but Rosie, you go first and we'll see if it was.
Just a few points. One, Imelda, is that I just want to say a very big thank you. Do you mind just turning your microphone off, actually, because there's quite an echo. That's lovely, thank you. I just wanted to say a very big thank you, Imelda, for all the work we've done together over the last couple of years. Our teams are working brilliantly together. A lot of the areas that you raise in the report, I know our teams are working together to make sure that we look at it from a regulatory point of view as well when the areas are raised with us. And it has been fantastic, your leadership of Healthwatch and your passion for hearing the voices of people has been really wonderful to learn from and watch. So thank you very much. Just on with regard to the integration and the integrated care systems, I think it's going to be incredibly important for Healthwatch to have a very strong role in integrated care systems, and that's certainly something I've been talking about when I've been doing my stakeholder engagement around ICSs, and I wonder if outside of this meeting we could maybe pick up a separate conversation with the most appropriate person in your team in terms of how we look at working together around that agenda. But thank you very much for all you've done.
So actually that wasn't what I was going to say, although I agree with it all. What I was just going to say, Imelda, in your normal understated way, you talked about the appalling state of dentistry in this country, and I think it might just be worth just being really clear what you were talking about was difficulty of access to NHS dentists, rather than a commentary on other aspects of dentistry.
Yes, do you know what, my brain was going, that's not very clear as I was saying it. No, dentists are doing a grand job. It's access that's the problem. And so when people get there, they get a good service. It's getting there that's is the difficult thing.
And specifically to NHS dentists. Yeah. Okay, thank you. Anything else anybody wants to ask Imelda. Chris.
You have to put your hand higher the further back you are. I just wanted to echo Rose's comments to thank you personally, Imelda, for the work that you and your team have done. I think we both have a common agenda about trying to drive change and improvement, and I think the way we've worked together over the last 5 years has really been a testament to your leadership, but also I think there's been some, we've managed to make some real differences, some real change, both highlighting where policy needs to change, but also practically what organisations can do. And I think the role, getting accessible information right in a post-COVID era, being clear about what people's expectations should be, and also access to services, how we still can hear the voice of people as ICSs emerge and develop, I think will be critical. So I think there's a very important role for Healthwatch moving forward, working with us. I'll be sorry you're not there, but I'm grateful for what you've left behind in terms of the team and the infrastructure to make that possible. So thank you.
Anybody else want to pay tribute to Imelda, other than me? So Sally, go on.
Thanks, Imelda. I don't know you well, but I'm sure everybody else is very honest in their tributes. There's something in the paper that you didn't mention around access to MPs and Parliament and also media. And I just wanted to give you the opportunity to say a bit more about that, because that leaps out at me as something that Healthwatch does better now and probably has more of an influence. And I just wondered if you wanted to comment a little bit.
Thank you. I was trying to sort of just stick to policy, but I think it is, it's in this report for you to read. We are having a concerted effort to make sure that the voices of people who use or need services are heard by everybody who has an influence to bring about improvement. So we've really stepped up our work with parliamentarians, really supporting parliamentarians in their debates, particularly, so that they have the information to make sound decisions, and also building longer-term relationships with parliamentarians. Likewise with the media, it took a while for us to get our voice in the media. Getting the tone right is really important. We could be on the front page of the Daily Mail every day if we wanted, but getting the tone right so that you build strong partnerships and make sure that people get the nuances of what's going on is quite hard. And I think we found that it took us a while to get there, but I think now that we've got, our evidence is so much stronger, it's easier to tell that nuanced story. We say no a lot to media, and will do. Thank you.
So I was sorry, did you want to come in, Annie? No. So I was going to say, Imelda, that before you and Robert arrived at Healthwatch was a really good idea that hadn't quite worked out how to perform its role. And since you and Robert have been there, it's transformed. Robert, of course, takes all the credit for that, but I suspect that just a little bit goes to you as well, Imelda. So at the risk of sparing your, or not sparing your blushes, I just want, on behalf of the whole board, to say thank you very much for all you've done, and to wish you well in the next step in your life. It's been great working with you. So, board, that I think brings us to any other business, if there is any. I haven't been notified of any, but does anybody want to raise anything? In which case, that is the end of the meeting. But we do have two questions from one member of the public, Robin Pike. And the first question is, how does CQC regulate large GP practices formed from the amalgamation of smaller practices, taking into account any differences in demographics? Rosie, I think that's one for you, please.
Yes, thank you, Peter, and thank you, Robin, for the question. We're doing a lot of work in this area. There's two scenarios really we're working through. One is what we're calling primary care at scale providers, which are practices that are large practices working under one corporate umbrella. And the other is that we're increasingly seeing primary care that practices come together under primary care networks, which have a whole variety of legal structures. And the way that both with the primary care at scale and the primary care network providers are regulated depends a little bit on their legal structure and how they're registered with us. However, having said that, the work that we've done to date and the work we've done with the public shows that actually the public are still very interested in what's happening at the specific location that they actually attend for their care. So we're still regulating at the moment, mostly in the looking at the locations that people attend for their care, but trying to understand what can we do at that corporate level across all providers. And we do have relationship owners with those with each of those large providers to make sure that we get a good understanding and a good picture of what's happening in each of the different practices that they run, and just make sure that if there's a problem in one, we investigate or we look into whether that's a more general problem across all of the different providers locations. We are continuing to work closely with stakeholders like NHS Confederation and others to really understand the developments within primary care networks and primary care at scale providers, so we can continue to develop our regulation around this.
Thanks, Rosie. And Robin's second question is, how does CQC regulate NHS hospital trusts that have large independent hospitals on the same site, when as much as 40% of their activity may be in the independent hospital? I'm not sure that that's quite an accurate statement of what happens, but Ted, you might be able to answer the general point of the question.
The general point is that the NHS Trust and the independent hospital are usually completely separately registered organisations, and so are regulated individually as separately regulated organisations, registered organisations. We would inspect them separately and we would report on them separately, and we would take any enforcement action if it was necessary against them separately. One of the things that we would look at is how well they worked together to provide joined-up care for patients, because, of course, a lot of independent hospitals have significant NHS contracts, as Robin highlights. I don't doubt whether it's 40%, but they often have significant NHS contracts, and we'd want to make sure that they are working effectively as part of the system, providing integrated care. And I think with the development of integrated care systems, there is again more opportunity to make sure that all parts of the system, including those parts that are provided by independent healthcare, are joined up and providing integrated care for individual patients.
Great, thank you, Ted. And that is the end of the public session. So thank you all very much indeed.